All right, so welcome everybody. My apologies for being a moment or two late. So we are fortunate enough to have Dr. Jay Howe with us today. Jay has been a colleague and a mentor of mine for many years now, and has a vast amount of experience in working with people with developmental disabilities, and he has is a wealth of information and resources for people. So Dr. Howe is a specialist in developmental neuropsychiatry and trained at the National Institute of Mental Health and Neurosciences in the United Kingdom, I believe in Cardiff. Jay, is that correct?
Yeah, that's right. Yeah.
In the United Kingdom, I think I don't want to say they take developmental disabilities more seriously, but they take it more seriously in psychiatry in particular. And in fact, it's a subspecialty of psychiatry. And I don't know how much, Jay, do you know how many other Canadian psychiatrists have completed subspecialty training in developmental disabilities in the United Kingdom? Or are you it?
No, there are some. There are probably a handful.
But I think it says a lot to how much they recognize the importance of it, and having that subspecialty training, again, has provided you with the opportunity then to sort of share that information and knowledge and experience with residents and medical students. And I think that's incredibly highly valued. Jay is an associate professor in the Department of Psychiatry at Western, and is the director of postgraduate education within the Developmental Disabilities program in the Department of Psychiatry. Dr. Howe is the physician leader for the dual diagnosis research and treatment program at Parkwood, and also heads the clinical team at the Central West Specialized Developmental Services. So Dr. Howe, in addition to working clinically, where his services are much sought after, and Jay is one of the busiest people I've ever seen and works in 30 different places as far as I can tell. Dr. Howe has taught internationally, has published research in international journals, and is, as I said, highly sought after as a clinician and as a teacher, both nationally and internationally, and is really highly respected for his work, particularly with adults with developmental disabilities, which is an area of tremendous need, and there's a real lack of services and expertise in that area. So today, Dr. Howe will be talking about multi-factor assessments in developmentally disabled individuals with complex needs. So Jay, thank you very much for joining us. And the floor is yours.
Thank you. So, one of the disadvantages is that in a format such as this is that you're talking to my computer screen. And I'm very familiar with my computer screen. It's been with me for quite a few years, So I see some names, and I hope I have no idea what your experience is in relation to developmental disabilities, but I assume that you're all in some way connected with developmental disabilities, especially patients with developmental disabilities, or you have some research interest. So I assume that that's the case. So forgive me if I sound very condescending. I'm not really going to be condescending, but if you're an expert in the field and I'm talking to you about basic things, sometimes one may find that that's not desirable. But let me start off with a sort of brief introduction, which is basically, when we plan individualized interventions, the first step often is you have to define the problem clearly. So, for instance, when we define dual diagnosis, we have to define it very clearly, and therein lies the problem. Because there is no standard definition for it, and such definition there is very variable, in terms of how people understand it. So there are lots of issues, and there are problems with really applying established diagnostic systems in this population as well. So establishing validity, in an area such as behavioral or psychiatric diagnosis in intellectual disabilities is difficult because there is no gold standard, already existing in this So it becomes very difficult for service providers to apply evidence-based interventions. Now, the question then is, what is evidence? Where is the evidence? How was the evidence that we derived? What population was it applied to, and so on. So there are lots of issues, okay, with that. So I won't go into the details with regard to the various controversies, in relation to dual diagnosis. So let's just sort of focus on some practical things. So one of the questions that I get asked by residents, by students, by other physicians who refer these individuals to me is, what's going on with this patient and how do we deal with it? So they're not interested in all the controversies and problems with definition and so on. So I'm going to focus just on that today. And so we have had a long, I've worked in this subspecialty for 40 years. And, one of the, and throughout that process, I've realized that we don't know much about this, okay? So even today, the outcomes for this population is the same as the outcomes that we had 40 years ago. So therefore, it isn't as though over the last 30 or 40 years, we have traveled a great distance in understanding how to treat these individuals. Okay, we have used different medications. Okay, but ultimately, our really, interventional method is pretty much the same. And quite often it's haphazard. So how do you bring order to this? That's been my quest for a long time. And after really sort of considerable experience and working with my colleagues, from speech and language and occupational therapy and behavioral therapists, behavioral analysts, and parents, and gradually over time, we have crystallized an approach. And I'm going to talk to you about that, essentially. So let me start sharing my screen, and I hope I'm there as well. Please let me know if you see both the shared screen and myself. Do you see me as well?
Yep, looks fine, Jay.
Okay, all right. So and I need to be certain that I'm talking as well, because I have to look at myself and say, yeah, it is me talking. So otherwise, I'm just looking at the screen. All right. So essentially, I'm going to talk to you about multi-factor assessments. Now, what does multi-factor assessment mean? Because we have just 40 minutes. I won't go into a great deal of research and background and so on. I'll just get down to the basics. Right? So, in relation to multi-factor assessments, and we kind of, after a considerable amount of work, we arrived at this, that when we assess these individuals, we have to assess them multifactorially. And this was known all along. This is not just a sort of kind of eureka moment when I suddenly sprang out of the tub and said, oh, I've discovered an approach. It's been a sort of really slow process, right? So the objectives today are, I'm going to briefly define dual diagnosis. Then we will try and understand behaviors and the process of diagnostic decision making. Okay. Then we'll try and conceptualize behavioral problems from a multi-factor perspective. And I'm going to explain what that multi-factor perspective is. And then we'll learn a little bit about multi-factor assessments. And then I'll have some case examples.
Jay, if I could just interrupt, there was a question in the Q&A. If you can just hit the enlarge part of the slides, because otherwise they're a bit small, in the top right corner.
Okay, all right. I can do that. Yeah.
Yeah, and we can still see you. Yep, we can still see you.
Okay, so is this okay in the screen?
I think so. Yep.
Okay, so and then I will briefly introduce you to MultiFactor Assessment tool. It is a tool that I've developed and that we have tried over a number of years, and we found it extremely useful. Okay? And it's due for publication very soon, and so it's going to be copyrighted, but obviously, it will be available free of cost to anybody. So this is basically a tool that I will talk to you briefly about. Okay. So in terms of diagnosis, what are we talking about when we talk about dual diagnosis, behavioral problems in the developmentally disabled, and so on? So we are essentially talking about developmental disability, combined with, say, behavioral problems, and it says and/or psychiatric disorders. But the problem with this is that it doesn't give us a comprehensive picture. It tells us that there is a behavioral problem and there is a psychiatric disorder and/or. And one of the assumptions that people come to is that it's integrally associated with psychiatric disorder. Any behavioral problem has an underlying psychiatric illness, underpinning it. So that's not always the case. In fact, only 30% of individuals that we see, especially in our clinics, have a psychiatric diagnosis. The remaining 70% have significant neurobehavioral problems, but they do not have a psychiatric diagnosis. They have other factors that leads to behavioral problems. Okay, so therefore, this kind of definition does not really emphasize the multifactorial causation. It kind of limits our vision and understanding. We either think of it as behavioral or it's a pharmacological intervention, right? So we ignore the neuromodulatory and neurodevelopmental vulnerabilities on behavior. So let's talk about the vulnerabilities of the dual diagnosis. Who are we looking at with this problem? Okay, first of all, we have to define the person, right? So the people that we usually deal with have certain characteristics, and most are unable to communicate verbally in a clear and understandable way, and they may have difficulty in understanding others. Most are unable to find expression to their inner experiences. Most have difficulty with abstract thinking. They may not be able to problem solve. They may expect others to understand their difficulties and resolve the issues for them because they have no problem solving skills or, poor problem solving skills. And these are things that you all know. And so they have significant cognitive impairment, and it doesn't have to be just intellectual disability. They have other cognitive impairments as well. And they may have multiple physical malformations as well. So, and on top of it, they may have a kind of disorganized wiring, in the developmental brain, resulting in dysregulation of several systems. And, these are all concerned with modulation of brain functions, like the sensory system, the executive brain function, the attentional system, and so on. Okay. So in other words, we are really dealing with persons who have a constellation of problems that are fairly significant, from a physical perspective, neurological perspective, and behavioral perspective. Okay. They also have higher incidence of many psychiatric illnesses, and I won't go into all the statistical details about that. They have higher incidence of neurological problems such as epilepsy. In fact, amongst our population here in this clinic, which is obviously a specialized clinic, about 70% of individuals that we see have a neurological problem of some sort, and about 55% have epilepsy. Okay? So it's fairly significant. And they have higher incidence of cardiac, gastrointestinal malformations, and then underlying that, there is communication and sensory disorders as well. So these are individuals with multiple problems. Okay? Now, on top of all of this is overlaid behavioral problems like aggression, self-injury. So we then have to kind of understand how those problems, aggression, self-injury, fit in this context? Okay, so the other issue is, so once we've sort of dealt with the individual, what is a behavioral problem, right? So, but behavioral problems are really very non-specific from a diagnostic perspective. It's really a lay term, okay? But it's quite descriptive, okay? But it's very non-specific. And one of the things that we found is aggression and self-injury are the most common behavior issues leading to referrals. At least to our specialized program, most of the individuals, about 87 to 88% of individuals that we see, they have their primary referral is for aggression or self-injury or both. Okay. So, and behavioral problems can be the final common pathway to the expression of a number of issues in these individuals. So we have to bear that in mind. So to summarize all that, so when we see an individual who has significant behavioral problems, and we assume that that's because of some sort of psychological distress that they are experiencing, you will find that a number of different factors impinge on that. They have an influence on causing that distress or making that person vulnerable to developing distress, right? So, for instance, you can look at psychiatric factors, communication factors, emotional factors, environmental factors, medical factors, sensory modulation issues, executive brain deficits, and developmental factors. So I'll briefly highlight that with the case example afterwards, but just keep this constellation in mind, as we go through. Okay. So if behaviors are driven by such complex underlying factors, the question is, how can they be assessed comprehensively? Okay. Is there a simple way in which we can assess this? Or, even if it's a more complex way, is this a time-efficient way in which we can assess all of these factors and really gain an understanding of what's driving these behaviors? Okay. So that's the challenge. And that's what I meant by, I struggled with finding a way to actually assess these individuals for decades, and came up with various approaches, refined them, discarded them, and looked at other options and so on. Okay. But first thing first, this is my favorite character. I watch his cartoons regularly every day. So, but before beginning a multifactorial assessment, we have to determine what the behaviors signify. We did say that behaviors are a final common pathway to the expression of a number of different things. But what do they actually signify? When you see somebody with severe self-injury or aggression, what's the significance of it? What do we need to do about it? So, but for that, you have to make some diagnostic decisions, right? So one way of actually making those diagnostic decisions, when we determine what the behaviors signify, we are making a diagnostic decision. So when I first encounter a patient and the patient comes with, say, a history of self-injury or aggression, the first question I ask is, what is it? What is this behavior telling me? And one way of really understanding that initially is a method developed by Gardner and Sovner some time ago. So, and I find it very useful. The first question I ask is this a first order behavior? Is this a second order behavior? Or is this a third order behavior? Okay. And I'll explain what those things are. So once I've clarified that, I can then start looking at the underlying reasons for all the other factors underlying the behaviors. Okay. The first step, obviously, is what is a first order behavior? Now, first order behaviors, somebody comes to me in eMERGE with severe self-injury, okay? So I'm going to ask myself, is this a primary manifestation of the disorder? Does the behavior reflect the illness itself? You know, for instance, in some cases, say, for instance, somebody comes to me hearing voices, auditory hallucinations, and especially third-person auditory hallucination, commanding hallucinations. Now, that is a symptom of schizophrenia. And schizophrenia cannot be separated from that. You know, the two, of course, the voices are heard in other conditions as well, but it seems to be almost a manifestation of the illness itself. You know, like myocardial infarction. The infarction is a manifestation of the heart's problem, right? As underlying vascular problem, right? So motor tics are a manifestation of Tourette. There is no Tourette without motor tics, right? So that's just first order behavior. You know, once I look at that and say, okay, what we are seeing is this a primary illness that we're looking at, okay? And once we have clarified that, then I look at whether it's a second order behavior. Second order behavior is usually, it represents a worsening or increase in previously present behaviors, right? So the person coming to eMERGE with this severe, say, aggression, what is this? You know, is this suddenly occurring out of the blue, or is it a worsening of a tendency that he has always had? So if I find that this is a habitually aggressive person, I then ask, why did they come to the eMERGE now? So was there an increase in physical aggression? If there was an increase in physical aggression, then in a habitually aggressive person, then I'm asking myself, why is there an increase? You know, is this person experiencing anxiety? Is this person experiencing sadness? Or did something change in his environment to make this person more anxious, and then does it lead to an increase in physical aggression? So that's the second order behavior. So if I decide, okay, this is a habitual pattern with this person, and the thing that I'm seeing now is just an increase because of some other change, then I can look for that change and resolve that. And then there's the third order behavior. Third order behaviors are actually new behaviors during the course of an illness. It may be in response to a caregiver's reaction or a family's reaction. And typically, this relates to one of my patients, an individual who has fear of open spaces, was very happy during the pandemic because he didn't have to go anywhere, for 2 years. And then the pandemic ended, the day programs started, and then he was forced to go to a training center. And then he became extremely self-injurious. So when I asked myself, okay, is this a third order behavior? Yeah, it was the case. So this was a new behavior. He had never been self-injurious before. But he had a fear of open spaces. When he was forced to go out, then he started this new behavior. So then, I have an understanding of it. Okay, now maybe we shouldn't actually force him out, but we have to desensitize him and gradually get him out. So, it suddenly sort of clarifies some things for me right at the beginning. So once I have done that, so the next step is to look at, okay, how do we do a multi-factor assessment? Okay, let's look at other causes. What other things are contributing to this? So I'll give you an example of a patient. I have a 19-year-old individual who's wheelchair bound, and she lives with a single mother. And she graduated from school, and she remains at home. And gradually she became more and more aggressive, actually self-injurious as well, defiant and very withdrawn. She would scream day and night for lengths of time. Nobody could actually cope with that, and neighbors were complaining. single mother. She was really stressed out. She couldn't get any sleep. So it was quite a significant issue. And she was frequently taken to emergency, And every time she went there, she would come out with a different diagnosis, right? So quite often, she would be asked, are you hearing voices? And she would say yes. Quite often our individuals do that. Yes, I'm hearing your voice. Yes, I do hear voices of people talking to me. So, it's hard for many individuals to actually separate, that there is a phenomenon known as hallucinations from, okay, I'm hearing somebody's voice, which is real, right? So they often, answer in the affirmative, they say yes. So a diagnosis of schizophrenia was made. And once the diagnosis went to the chart, every time this person went to emerge, somebody looked back and, oh, the patient with schizophrenia. And then, different medications were tried. So what did we do, with that? So we admitted this patient. She was referred to us for admission. And so we went through our multi-factor assessment. This is basically what we have actually developed, So we feel that there are 9 different factors that we need to consider when we are assessing individuals. Okay, and I'll go through them systematically. So basically, biomedical factors, psychiatric factors, developmental factors, environmental factors, sensory modulation, communication, emotional factors, that relates to neglect or abuse and things like that, and behavioral factors. These are functional behaviors and executive brain dysfunction. Okay. So we started looking at those 9 different factors in this individual. So what did we find? Okay. So factor 1, biomedically, obviously she was in a wheelchair and she had a number of problems, right? So she had epilepsy, had petit-mal activity, she had pain, migraine headaches, legs, hips, spastic back, causing pain, and so on. And there she had a whole host of other medical issues as well, from lazy bowel to G-tube for feeding with meds, and history of aspiration pneumonia, dislocated hips, and prolapse, feet deformity. So this poor girl had, everything happening to her. Okay. So, but the question is, okay, she has all of these things. Is this what is contributing to her difficulties? So we have taken this into consideration and we found a number of factors here. So see, that is the problem with our decision making. Now we can't say, okay, just because she has these things, these are contributing to her behaviors. But this is a factor that's present. Okay, so let's go through all the factors and then decide how we design our intervention. Okay, so the second factor, psychiatric, and we actually carefully assessed her. There was no psychosis. Okay, absolutely none. And she was not depressed, and depression was usually situational. When mom went away and she was alone in the house with her brother, she didn't get along well with her brother and she would get depressed, or when she didn't have something, she would get depressed briefly, sadness rather than depression. And she had impulse control problems. She had episodes of aggression, physical and verbal, but that's it's not indicative of any psychiatric issue. And she was said to have OCD. That was another diagnosis in her chart, but she was mainly arranging clothes and videos in a certain order. Okay? And that was her main issue, but she had this autistic sense of sameness, and she would order everything in a certain way, but that was not really OCD. And OCD is very specific. So then we went to the third factor. Obviously, she has all of these issues: muscular dystrophy, spastic paralysis, spastic back, and so on. I'm sorry for this term, but this was what was in her charts, right? And she had a good verbal ability, but limited vocabulary, and we will talk about it later on. So essentially, this is her. Okay, with this set of conditions. Now, when we look at the fourth factors, there was no history of trauma, neglect, abuse. Mom was burning out and she was getting tired of providing constant care. But, she was a very good mother. And so fifth factor was environmental, and they lived near a fire station, we found out, okay? So fire trucks were constantly coming and going, and the fire trucks, the sirens would make her anxious. In large crowds, noisy crowds, routines changes, upset her. She had lost an uncle and aunt recently. She lost all her school friends. When she finished school, she had a few friends, but she could no longer connect with those friends. That was a loss. And stress, she had a lot of interpersonal issues at home, because she felt that her mother didn't pay her as much attention anymore. And of course, she didn't recognize that her mother was burning out, and negative experiences, a lot of family dynamics there with brother, mother, lack of reinforcement of good behaviors, and there is no structure, and then a lot of conflictual situation within the family. So there were lots of issues going on in her environment. Okay. So then, we looked at her sensory vulnerabilities, and she had a number of sensory vulnerabilities as well. Low threshold for touch, high pain threshold, intolerance to noise, low auditory visual registration, proprioceptive modulation difficulties. And that's basically, she did not feel her body in space. So it's like the leg going to sleep when you've been sitting down for a long time, you don't feel it in space. So the body went numb. So the only way she could activate her receptors and make her body come alive was to constantly move, fidget and rock and bang and so on. The more, she engaged her muscles and joints, and, the more the proprioceptive receptors started firing impulses, and the brain suddenly became aware of the body, and so therefore much of her excessive activity was due to that. So then communication deficit, she had lots of communication problems. She had articulatory problems. She was better at receptive language, but she was very concrete. She had auditory processing difficulties. And typically when I talked to her and asked her to repeat back what I said, quite often, she would say something else, right? That's typical of auditory processing difficulty. So in other words, she had lots of problems. When we analyzed her communication in more detail, we found all of this, and I won't go into all of the details here, okay? So she only attended to fragments of what you were saying, then she filled in the blanks and came to different conclusions from what you were trying to say. Okay. So the eighth was, functional behaviors. She was aggressive, she was property destruction, self-injuries, impulse control, verbal aggression. This is the kind of, and this is the topography of her, behaviors. Okay, and we did a detailed functional assessment on that as well. So when we put it all together, so what we found was this graph, right? So factor 1 to factor 9. So the multi-factor assessment looks at how severe each item in each factor is for that person. How severely is it rated? Okay. Now, based on that, you derive a score, and then you do you apply proper weighting corrections, and then you derive a final thing. And then based on that, we find that factor 1, the biomedical factor, came up to here. Psychiatric factor was 0. Then when you looked at factor 3, it's a developmental factor, it was over there, and then factor 4, was really, emotional factor, which was 0 because the neglect, abuse, it was not there. And then when we considered environmental factor, it was high, right? And then similarly, sensory, speech and language, and then functional behaviors and executive functions. These are all out there. So when you look at this graph, it gives you an idea. It says, okay, the first thing that I have to address in this person is the environmental factor, because that is really weighing heavily on this person's resilience. Okay, so this is contributing more to her behaviors than anything else. So, and then, I focus all my energy on this, and then we can address some of these. There's a line here. They're all of equal importance. This is, so we can address those things later on. But the most important thing is this, okay, is the environmental deficits or environmental triggers. Okay, so what we actually did was, we did a lot of work. Our social worker went to their home, found that it was not wheelchair friendly. So she used to be wheeled into the wheel, used to be tilted, and they would put the wheelchair in there, and then she would be sitting there, and she wouldn't get out of the room. She couldn't be easily taken out of the room. She was stuck in there. So these are all realized when we started looking into it in more detail, and the noise and the sense and the accessibility problems and the family dynamics within. So we provided a lot of counseling help, and we did a lot of work with the family, with the brother who was feeling left out because he felt that mom was focusing all her attention on this individual, resented her because she said, oh, she's attention seeking. And so, when we resolved all of those issues, it was very helpful. So this is how we actually developed our conceptualization of this person's problems, and then we developed an intervention strategy. Okay. In other words, so when we looked at it, we realized, these were all the various things. There are a few community-based options, house not wheelchair friendly, totally dependent on others for personal care. Forget the him there, because I wanted to really, I didn't want to identify this person as a female, but but then it ended up. So numerous biomedical conditions, sensory modulation difficulties. So these were all addressed as well. We suggested a lot of sensory approaches. We provided iPad with Proloquo, to go, and then with lots of communication interventions as well, and then lots of support for her. And then we developed some community-based option for her to go out and get more passport funding and people taking it out. So all of this had a significant impact. And for more than 2 years now, we haven't even had to follow up with her, because we have given them the option of contacting us should it be necessary. They haven't, and from time to time we get the update, saying that she's doing well. So this contrasts with our piecemeal approach. When come, do you hear voices? Yeah, that's schizophrenia, or it's behavior, it's and so on. So it's therefore important for us to take this comprehensive approach. Now, what I will do is I'll briefly show you the actual instrument, and let me open that up. Okay, it's already there. Hold on, I'll stop sharing that, and I will share the other one. Okay. Can you see the multi-factor thing? I can't see it. So.
What I can see, Jay, is an Adobe Acrobat symbol and something that says MFA 22, Adobe Acrobat Pro 2020.
Okay.
So no. Although, I mean, it looks like below, it looks like that's the top of the screen or something.
Okay. Let me try once more. Oh yeah, I got it. So I will share this.
Yep, it's already sharing, Shay. We can see it now.
Oh, okay, good. So this is the instrument that we have developed. And so this, say, biomedical conditions. Under that, these are the most common conditions that we see, epilepsy, medical disorders. And again, we've made a list of all the things that we have encountered, so, this is not a figment of anybody's imagination, but these were all things that we have actually encountered in our patients, right? So neurological problems and vision problems, hearing problems, sleep disorders, medication related. And say, for instance, in medication related, we have various things like akathisia, abnormal involuntary movements, constipation, drooling, dystonia, and so on. Okay? And then psychiatric conditions, the various things that we encountered. And and then we look at developmental disorders, which is the third factor. So various different disorders that may be present, because some of these conditions have a behavioral phenotype. Like for instance, if you take Williams syndrome. Now, Williams syndrome has a behavioral phenotype. They tend to be more articulate, but they are more anxious. They have panic. They're prone to panic and so on. Fragile X. They have a lot of anxiety disorders, agoraphobia, and so on. So Prader-Willi syndrome, it comes with a definite sort of behavioral phenotype. So it's important to actually define some of that because, say, for instance, with PKU or say fetal alcohol syndrome, there is significant executive function damage. Okay, and so we need to consider that as well. And so perinatal conditions and all of those. So then sensory processing, a whole list of different things that we usually find, from tactile function problems to, really self-regulation difficulties. In fact, we notice this self-regulation difficulties as the most significant, and we are doing some work with our occupational therapists on that. And so environmental factors, change in environment, stressful care provider skill competence deficit, conflictual home environments, legal financial difficulties, and so on. Communicationally, a whole host of things, speech problems and language problems, auditory processing disorders, and then functional behaviors here, and then executive functions. This is my special interest. So we do a formal executive function assessment for all of our individuals, and we see a number of domains of executive deficits, in our population. So it starts from, so these inhibit, shift, emotional control, self-monitor, they are the behavior regulation indices, okay? And they indicate to us how efficiently or inefficiently the person is regulating their behaviors. And the rest of them, the working memory, initiate, plan, organize, they're all metacognitive skills. They tell us how efficiently the person is able to problem solve and so on. So this is very important. And we have found that 86% of the patients that we see have executive deficits. And usually the most significant domain of executive deficit that they have is usually shift. Shift is the ability to shift their mental sets and move flexibly on. And if that is affected, you get stuck. You get in loops. You become perseverative. you repeat the same motor actions or verbal actions over and over and over. So that's typically a problem with shift. And we found that almost 92% of individuals with executive deficits in our population have shift difficulties. Okay? And then obviously we also use certain instruments, and we look at various disorders as well. And this kind of completes the multi-factor assessment. What we have done is we have then taken this and put it into a multi-factor care plan as well. So that brings all the disciplines together. So when we look at it systematically in this fashion, now we say, okay, biomedical condition, our physician on the unit has to present to us what the biomedical conditions are, the progress or the regression with that, and the speech and language pathologist is over there, and she provides her assessment reports, and she'll specify what needs to be done and what the progress is. The same with our occupational therapist with sensory issues and so on. So, when we actually discuss patient's progress, we have this systematic way of actually bringing all of them together, contributing to a single document, and really working towards enhancing the patient's progress. So it's very useful that way. So in relation to so I will stop sharing that, and then okay. So in summary, I think we have to sort of keep in mind, it's very important that we take a multifactorial approach, multi-pronged approach, really. So you don't sort of place all of one's emphasis on psychological, behavioral, or pharmacological, or social interventions alone. A systematic multi-factor approach with careful assessment of neurodevelopmental, psychiatric, environmental, and other vulnerabilities helps us develop a more rational, thoughtful, and scientific clinical approach. And also it leads to interprofessional collaboration, okay? And such as state-of-the-art assessment and collaborative treatment strategy would eventually replace the speculative, fragmented approach that has unfortunately dominated our conceptualization and management of dysfunction in this population. So, so I will now get off my soapbox. Thank you. Any comments, any questions?
Jade, thank you. That was a fantastic sort of description of the approach taken, and it is wonderful in its straightforwardness, but also covering everything. And I think the DSM system, now they've decided to get rid of the multi-axial system, I think potentially misses a lot of the things that you've described here that we need to consider with any patient, frankly, but perhaps more so in the developmental population. And obviously, with all your experience, I mean, it's been a fantastic system you've developed. So we have a fair amount of time for questions or comments. So if people want to ask questions aloud, which I think allows for more discussion, as I've said in the past, please use the raise your hand function. If anybody is shy or doesn't want to speak or whatever, please use the Q&A function, but not the chat function, because otherwise it's difficult to keep track of everything. And Dr. Goldberg and others have raised their hands. So Dr. Goldberg, I will, well, it says I'm allowing you to talk, which makes me a bit silly, but yeah, go ahead, Ben.
Okay, can you hear me okay?
Yep.
Very good. First of all, I'd like to congratulate Dr. Howe, and I'd like to take some credit for Dr. Howe coming to London. He mentioned the Cardiff, being educated at Cardiff, and that was under the great Dr. Fraser. And Dr. Fraser, of course, was one of the leaders in dual diagnosis and founded a journal And when I found that Dr. Rao had studied in Cardiff, I said, you've got to leave Woodstock and come to London and join the university department. So I think that that's one of the last accomplishments. The other thing that Dr. Rao has introduced is the concept of looking at executive functions, which was brand new to me. But the complexity of dual diagnosis may sound frightening to a first-year resident psychiatry, but one has to recognize that in the field of dual diagnosis, one really requires a team, and that all of these factors really are put together, perhaps by the supervising psychiatrist. So not to be frightened, but to dive in and follow the directions and leads that Dr. Rao has mentioned. That's it.
Well, thank you, Bennett, and kudos for you to you for the foresight to ask Jade to move to London. So that's a fantastic pairing. Joanne Morrison has a question. So Joanne, if you can just unmute yourself, you can go ahead.
Hi, I'm a social work clinician in a facility in BC that does very similar work to the facility you work in from the sounds of it. I have a couple of questions. So the tool that you put forward, it sounds like that you use that tool, your team uses that tool to summarize findings after you've done some assessment. Is that correct?
Yeah, that's correct. I mean, initially, we used it before the, person, as soon as we encountered the patient, and we would but then we realized that, there were lots of gaps. So we usually give it, a couple of weeks for everybody to complete their assessments. And then, we develop this in collaboration with the care providers, and so, yeah.
And how long are your assessments usually, your inpatient assessments?
Yeah, it's both inpatient and outpatients.
Right.
Mm-hmm.
We do both. We do both as well. But how long? How long is a typical inpatient assessment, roughly?
It obviously, it depends on when our team can complete the assessments, right? So what we do is we do preliminary assessments. We have a care plan meeting within 2 weeks of encountering the patient or the patient getting admitted. So at that time, we actually, our team participates, and I do the interview. I take the lead, and our team observes. Okay, and I do go through a full checklist, of communication deficits and sensory deficits. That's part of my psychiatric assessment. So from that, they may ask additional questions, but we already have a preliminary idea of what these person's vulnerabilities are. Like, for instance, we may decide, okay, this person has proprioceptive modulation difficulties, has communication deficits of this type. So initially, we develop a care plan incorporating those things. And as we do our assessments and get into more details with regard to that, now we actually add flesh to it, and then we develop specific approaches.
Okay.
So
and what is the end product that you provide to community?
Yeah, the end product is, basically a summarization of all of this from a multi-factor perspective.
So you provide a summary of what's in that tool, and
so
talk about the strategies that you've tried. Is that?
There are two. I work here in London as well, and then I work with the Central West region as well. In Central West, what we do is at the end of it, we provide details of all our assessments, from occupational therapy, sensory assessments, communication assessments, and everything. Each of us summarizes everything, and in fact, we put it on a disc, on a CD, and give it to the family. So all of that information is in there. So they have a complete summarization of everything that we did. We haven't reached that level of sophistication here in London, because we are just emerging out of 18th century. But we do try to provide, I try to summarize everything and provide documentation.
Okay. So the care plan that you implement is the care plan you implement during your assessment. It's not a care plan created to be implemented by the community partners. It's for your own team.
Yeah, but for inpatients, we implement the plan,
Mhm.
and then we actually, and even in in Central West as well, our team starts, takes the lead in implementing this, and then through that process we also train, the staff working, and then we withdraw. And we have a 5-bedded inpatient unit there in Oakville, and we actually, when we admit patients there, 1 month prior to, 2 weeks prior to discharge, we actually have care providers come and work with us during the day, observing what we do, participating in what we do, getting trained in what we do. And then when they're discharged, our staff, one of our staff actually goes and works with them for 2 more weeks in their group home or family home, and continuing the training, enabling the transition. So it's a process.
Yes. Thank you very much. I really like the topic areas that you cover in your tool there. I think it's quite comprehensive. Be interested to know how we can get a hold of that at some point. But thank you for answering the questions.
Thank you.
So Jay, Dr. Jacqueline Ogilvy, who's a developmental pediatrician at Children's Hospital at London Health Sciences Center, had a question similar to Joanne's, but different. But so the question is, are you gathering data on the outcomes and satisfaction of people who have been cared for using this approach and sort of with a diagnostic approach and results, as opposed to those without? And I think Jackie's question really relates to, how do we translate this and use knowledge translation to convince people in management and other places that, this really provides the optimal care for people and provides far better, presumably satisfaction, but also outcomes. And so is that something that you've been looking at?
We've been looking at it informally, but we haven't specifically looked at it, because initially when we started, when I was asked to lead these programs, I found that I couldn't do my work unless we had collaborative working arrangements. So initially it started off, how do I bring everybody together to work collaboratively? And then, that's how, we started developing it, but then, it developed into this. So in order for us to do that, we have to actually have a sort of comparison, are people more satisfied with the previous, or are they more satisfied with the present? And Oakville, we do have a systematic assessment of the satisfaction of clients, a client satisfaction survey. And when it relates to items concerning treatment interventions, the satisfaction is very high. Okay. And but when it concerns the global satisfaction, of course, there are other factors. Did like the diet, and did like attitude of the receptionist and all that. But essentially, when it concerns just treatment parameters, most are very grateful and very satisfied with it, highly satisfied with it. So, but that's not a sort of research project. This is just an audit.
But it's still information, right? And I think that it's hopefully can be used to present to people that, yes, it may seem a bit more labor intensive, but in the long run, it actually probably saves work down the road. I mean, have you, intuitively, it's also going to hopefully provide better outcomes, although maybe that's a hard thing, to assess. But is that something that you're planning on looking at?
Yeah, we do. So, of course, there are a number of possibilities here, right? In terms of what we can look at, but now that, once we have this instrument published, and then, we can then actually set up very specific research projects based on that. So what I would suggest at this stage is that, this is not as yet an intensive research project. So I won't be able to answer many of those questions, but once we have a publication, then that gives us it becomes a valid thing. And then, we can then look at, there are 3 or 4 different types of different projects. Both myself and our occupational therapist is also contemplating. Our director of behavioral services is contemplating some as well. So all of that can be, sort of, set in motion.
But I think, Jay, I mean, it's a fantastic approach, and I mean, don't take it wrong, but it's common sense, right? You want to look at everything in the big picture, but unfortunately, as you say, common sense isn't always common, but it's going to provide us a fuller understanding rather than, as you just said, just pumping people full of medicine without really understanding the underlying problem. And we know that approach doesn't work, and it's not good for people in the long run. So I mean, this was fantastic. Are there other questions or comments for Dr. Rao and the multifactorial approach that he's described? So Dr. Pavry has raised her hand. Give me 1 second there, Dr. Pavry. All right, you all you have to do, Dr. Pavry, is unmute yourself, and then you have the floor. Yep, you're good to go.
Thank you very much, Dr. J. It was fantastic to hear that comprehensive approach. As pediatricians, we are left with question marks as to where to send these complicated patients to go into the programs that you offer as 18-year-olds merge into your territory. So what is the approach that we should be taking? Yeah,
so the thing is that, I mean, you have CPRI, CPRI is also multidisciplinary, I mean, we have every specialty in there. So, I mean, that's the, your port of call, so, no. Yeah.
I'm sorry, I'm talking about after 18 because CPRI will not stop the child.
Yeah, after 18, obviously, we have our dual diagnosis research and treatment program here.
And what's the best number to call them?
I would suggest,
actually, Jay, if I can, I think if Dr. Pavry, if you just Google dual diagnosis program Parkwood, the referral form and the contact information and all that stuff is there.
Excellent, thank you very much.
Including Dr. Rao's office manager, and Tanya, who is really excellent, I think. And whenever I have a question, she gets back to me very quickly about it, and is really helpful.
Because I have several autistic patients that will get guidance from your treatment plan. Thank you.
I will have to emphasize that we have, at any one moment in time, we have about 370 registered outpatients that we see. And we have about 1,500 to 2,000 patient encounters a year. And I'm part-time here. So sometimes, for us to get to see somebody, it may take a little while. But I hate wait lists because wait lists are just an excuse for not seeing patients. But, we are trying to see patients as quickly as possible. And but, if you feel that there are patients who would benefit from our program, please go ahead and make the referral.
And if I could just echo what Dr. Russell said, this is a grossly underserved population. At least in children, at least there are developmental pediatricians and pediatric neurologists and child psychiatrists who often see these kids. But once they turn 18, there is very, very little to no expertise really across the country. I think, Jay, is it fair to say there's maybe 10 to 15 people who work with adults with developmental disabilities regularly across the country? And maybe that's a bit of an overestimate. I mean, unfortunately, it's just a grossly underserved area. And I think we're very fortunate to have Dr. Rao's expertise and experience, and also sort of the education he's provided to medical students and residents over the years. And I think, thank you, Jay, for providing this presentation for us. I think it's a great overview and sort of discussion and description of the work you do, and provides a really nice template or rubric that we should all be trying to follow, I think, in working with people with developmental disabilities. So thank you, Jay. This was a really fantastic presentation.
Thank you, much appreciated. Thank you for organizing these meetings. It's very useful for everybody. Thank you.
Well, I would love to take credit for organizing them, but I cannot. That credit would go to Sarah O'Flanagan. And along those lines of organizing things. So our next presentation will be on December 14th, where Dr. Maha Saleh from Geneticists at Children's Hospital and Dr. Claire Mitchell, a developmental pediatrician here at CPRI, are going to be talking about overgrowth syndromes. And we look forward to that on December 14th at 4 p.m. And so Sarah will be sending out notices about that ahead of time as well. So I thank you everybody for attending, and thank you again, Jay. This was fantastic.
Thank you.
All right.
Bye.
Take care.